No, computer is complaining, not you. You always complain, but now your computer is complaining.
The computer is learning from me.
It's called AI.
I'm just waiting for the YouTube to connect.
No, computer is complaining, not you.
That's great. And that's great. I'll give it a minute or two for people to join, and then we'll start. And more. Participant count. And more. So, just need to activate the chat function. That's great. Now, good evening, everybody, and welcome from iBreast Book again. This is webinar number 35. So it's been more than 2 years since we started all this, and it's great to see that we still have lots of people joining. The webinar today is about neoadjuvant treatments, and we have great speakers and panelists. So we have Marius Tasoulis from the Marsden, who's going to talk about neoadjuvant chemotherapy. Andreas Karkatanis from Uppsala in Sweden about neoadjuvant endocrine. Navita Sumaya, who's going to join later, who's going to talk about neoadjuvant radiotherapy. We have great panelists, include the usual suspects like Ash Kotari, who's been in most of those webinars from London. We have Prof. Ahmad Tarek Awad from Egypt. We have Rachel O'Connell from the Marsden, and we have Ravi Sharma from Scotland here from Aberdeen, and Prof. Sina Sukhon is from Jordan. So have a great panelists. Now, this has 1.5 CPD points, so you will all get certificates in the next week or so if you attend for a reasonable time. If you have any questions, please put them on the question and answer section, and we'll make sure that this is addressed. The chat function is for chatting, and you can see that there's already about 20 or 30 messages on the chat function. So it's very difficult to catch questions in the chat function. So if you have any questions you want, please put it on the question and answer section. We already have nearly 400 people online, which is great. I'm hoping to get even more because we have 1,500 registrations for today. And the first speaker is Marius Tasoulis. So Marius is going to talk about neoadjuvant chemotherapy. Marius, the next 20 minutes are all yours.
Can everybody see my slides? Perfect. So thank you very much, Yazan, for inviting me. It's great to be part of the iBreast Book webinar on neoadjuvant treatments. The topic of my presentation today is neoadjuvant chemotherapy and breast cancer surgery. These are my disclosures. So I would like to start with what we already know. And this is that surgery for breast cancer after neoadjuvant chemotherapy is safe. This has been shown in the meta-analysis by Maori, and also in the meta-analysis by the EBCTCG group, that surgery after neoadjuvant chemotherapy offers equivalent long-term oncological outcomes compared to the standard or traditional sequencing of treatments, which was to perform surgery first and then follow with systemic therapy as required. This has led to an increase in the utilization of neoadjuvant chemotherapy for early operable breast cancer. And now for certain subtypes, including triple negative and HER2 positive, neoadjuvant chemotherapy is considered the first choice for the management of these patients. Apart from the potential surgical advantages, and this is where we are going to focus on in the next few minutes, neoadjuvant chemotherapy can offer significant prognostic information to guide adjuvant systemic therapies, and especially escalation of systemic therapy after surgery. Two good examples are the Catherine trial that showed for women with HER2 positive cancer, addition of TDM1 in the adjuvant setting for those who had residual disease after surgery, improve the invasive disease-free survival, and similar findings from the CREATE-X trial that showed for women with triple negative breast cancer, capecitabine in the adjuvant setting offered oncological benefit. So historically, we have been using neoadjuvant chemotherapy to convert inoperable disease to operable. Currently, we are mostly using it to allow less radical and more conservative surgical approaches, and we will discuss about the future directions. So the potential advantages of neoadjuvant chemotherapy in terms of surgery include downsizing the disease, and reducing the size of the cancer may potentially allow more breast-conserving surgery. More breast-conserving surgery might translate to less requests for bilateral mastectomy, which is a significant issue, especially in the States. Less mastectomy may mean less breast reconstruction with all its complications and risks, less complex breast conservation, and we all know that if we excise less volume from the breast, then the quality of the aesthetic outcome is superior. Another potential advantage of neoadjuvant chemotherapy is downstaging the disease in the axilla, potentially leading to more axillary conservation. This could lead to less axillary dissection with all the morbidity that is associated. For clinically node-negative patients, now a sentinel lymph node biopsy after neoadjuvant chemotherapy is a standard of care to capitalize on the potential benefits of treatment. A bit more controversial is clinically node-positive patients converting to clinically node-negative. Currently, there is a shift from axillary lymph node dissection to sentinel lymph node biopsy and targeted dissection. A number of studies have shown that this approach is associated with low false negative rates, and this has now been endorsed by the latest NCCN and also the recent ASCO guidelines. So this means that with neoadjuvant chemotherapy, we may be able to do less surgery. Question is this a good thing? And the answer is definitely yes. Less surgery might mean more breast conservation, and this may translate in improved body image and reduced psychological morbidity, may lead to more axillary conservation with reduced rates of lymphedema and less functional impairment. It is important to note that many women value preservation of functional outcomes and reduce lymphedema even more compared to preserving their breast. And overall, less surgery will be more cost-effective for the patients, the healthcare providers, and the society. So in terms of breast surgery after neoadjuvant chemotherapy, the big question is how much breast to remove. And the answer is that this depends on the response to treatment. If there is no response to treatment, then we just need to follow the original management plan, and that would involve just removing the footprint of the disease. However, if there is response to treatment, then we have a dilemma, and this is either to remove what was the original footprint of the disease, or based our resection on the extent of the disease after neoadjuvant chemotherapy, so base that on what appears to be the residual disease on imaging. Current data suggests that we do not need to remove the original footprint of the disease, and this type of approach is now termed response-adapted surgery. Response-adapted surgery has been cautiously being adopted around the world. The results from the CALCB study showed that if surgeons are engaged with this approach, there was an increase in breast-conserving surgery by approximately 15%, and the majority of the patients achieved clear margins. The results of a meta-analysis regarding the use of neoadjuvant systemic therapy, and that included not only neoadjuvant chemotherapy, but also endocrine therapy, showed that of the women who had a mastectomy, 60% had a pathologic complete response. This means that we are very likely underutilizing this important tool that we have to try to avoid unnecessary radical surgery like a mastectomy. But why is there still a reluctance to de-escalate surgery? The evidence on response-adapted surgery is reassuring. This graph is from the EBCTCG meta-analysis that sparked a lot of controversy around the use of neoadjuvant chemotherapy. If we looked in the data, it appears that neoadjuvant chemotherapy was associated with a 15% increase in breast-conserving surgery. In terms of distant recurrence, there was no difference between neoadjuvant chemotherapy and adjuvant chemotherapy. There was a difference in terms of local recurrence, but if we exclude the studies that patients did not have any surgery, that difference was only 3%. A few things about this meta-analysis, which again sparked a lot of controversy. The results are based on trials from 1983 to 2002, so we would consider them historical now. The majority of the trials used suboptimal systemic therapy for what we would now consider standard chemotherapy regimens. For example, the combination of anthracycline and taxane was only used in one trial. And also, we have to bear in mind that this was in the era before the use of targeted anti-HER2 therapies. The decision about whether the patients would have surgery or not was based only on clinical examination with variable use of imaging. In 2 studies, surgery was not performed at all. And in 4 studies, neoadjuvant chemotherapy was not completed prior to surgery, but it was administered in a rather sandwich approach, chemo, surgery, and then chemo to complete the regimens. So despite these caveats, the difference locoregional recurrence between neoadjuvant and adjuvant chemotherapy was not significant enough, I think. And also there was no survival impact at 15 years of follow-up. What we also know now is that biology is what drives relapse and survival. Extensive surgery has never been shown to offer improved survival, and we already know this from the seminal clinical trials from the 70s. And for high-risk patients, it is a systemic and not a local relapse that it's more likely to be the most immediate problem. In addition, with the advances in systemic therapies and radiotherapy, we have now observed improved disease-free survival and overall survival. So therefore, with risk-adapted surgery in the modern era of multidisciplinary management of breast cancer, we are not anticipating increased locoregional recurrence rates. This is from a study from MD Anderson that looked into a more contemporary cohort of patients treated with neoadjuvant chemotherapy. These patients had anthracyclines and taxanes and anti-HER2 therapy. And as we can see, the 5-year locoregional recurrence-free survival is comparable to what we would consider acceptable even for patients not receiving neoadjuvant chemotherapy. Some people might think we need more evidence to follow this response-adapted approach. However, we have to be cautious because practice is moving faster than the evidence. It is extremely unlikely that we will have any randomized controlled trials to assess response-adapted surgery. And in addition, the event rate with modern optimal multimodality treatments is anticipated to be very low, making trials like that to design at least challenging, if not feasible. It is also important to note that during the 2017 St. Gallen expert panel consensus, the majority of the panel, above 80%, voted in favor of response-adapted surgery. So a plea for all the surgeons treating breast cancer about using response-adapted surgery after neoadjuvant chemotherapy. As we discussed, the use of neoadjuvant chemotherapy is increasing. It is now considered the standard of care, the first choice for women with triple-negative and HER2-positive breast cancer. These 2 subtypes constitute approximately 30% of all breast cancers. Advances in medical oncology, use of targeted therapies, and more recently, introduction of immunotherapy have resulted in pathologic complete response rates over 60%. And as we can see, the pathologic complete response rate is steadily increasing with these advances. Therefore, we have to take action. Otherwise, we may lose a major benefit of neoadjuvant chemotherapy for our patients. Question is how we can implement this response-adapted surgery after neoadjuvant chemotherapy. The most important, I think, point is to have patient engagement in a shared decision-making. It is very important for us to understand what are the patient's preferences in terms of surgery and what are the goals. We have to clearly communicate the uncertainties of this approach versus the benefits, and we have to manage expectations. It is also very important for the whole multidisciplinary team to be engaged surgeons need to collaborate closely with the radiology team, the pathologist, and the oncologist. Appropriate patient selection is of paramount importance. We discussed that biology drives response to treatment, so we have to identify which patients are more likely to have a good response. It's always useful to try to define what would be the surgery that would be required at diagnosis if patients were to have upfront surgery, and also what we anticipate to be the surgery at the end of neoadjuvant chemotherapy. It is always good practice to try to prepare for breast conservation and also axillary conservation, and this is by using clips to mark the tumor in the breast and any positive axillary lymph nodes. And very important, we need to monitor and understand the pattern of disease response. So we can roughly divide response to treatment into two groups. As we can see in the first group, we have no or minimal response. Hopefully now with better patient selection, we will not see that many of these women. In the same group, we also have the patients who have a patchy response. So as we can see for these patients, the footprint of the disease is not significantly different, and therefore, in terms of surgical management after neoadjuvant chemotherapy, most of the times we end up doing what we would do if we were to do surgery up front, so just remove the footprint of the disease. However, many women have either a complete imaging response or a concentric shrinkage of the tumor, and these are the women for whom response-adapted surgery to remove what appears to be the residual disease in the breast would be the ideal candidates for this approach. An extra challenge when we are discussing response-adapted surgery is the presence of microcalcifications. However, this should not always be a barrier. We have to bear in mind that not all microcalcifications in the breast are malignant, and it is important to try to biopsy microcalcs in order to be able to plan surgery more accurately. When the microcalcifications are known to be associated with DCIS or invasive disease, generally they do not disappear after neoadjuvant chemotherapy, but at the same time, we know that they are not a reliable indicator of disease. We analyzed data about the presence of microcalcifications after neoadjuvant chemotherapy in women who had a complete response of the invasive component and presented this at the last St. Gallen meeting. What we found was that presence of microcalcifications was not a predictor of residual DCIS and also was not an indicator of response to treatment. In terms of monitoring of treatment response, we know that imaging alone is not accurate enough to predict pathologic complete response. Therefore, multidisciplinary working is very important, and that involves a combination of clinical examination, imaging, and potentially biopsies. Post-neoadjuvant chemotherapy biopsy of the residual abnormality or the tumor bed and any microcalcifications may be helpful to guide response-adapted surgery. And this is an approach that we have been using at the Marsden to tailor surgical planning since 2013. And now just a few things about future directions. We discussed that historically neoadjuvant chemotherapy was used to convert inoperable disease to operable, more recently to allow less radical surgery. But in the future, we may be able to avoid surgery altogether in patients who have excellent response. Historically, attempts to omit surgery after neoadjuvant chemotherapy led to high rates of locoregional recurrence. However, we need to note that these studies were historical, and as we can see, the locoregional recurrence rate, both in the group of patients who had surgery and those who only had radiotherapy, would be considered high for modern standards. In addition, in these clinical trials, clinical examination was the only modality used to assess clinical response. Patients were not selected for omission of surgery based on cancer subtype, and we discussed about the importance of this, try to identify women for whom we are expecting to have an excellent response to treatment, and also there was no use of image-guided biopsy to assess response. So women who achieve a pathologic complete response would be the ideal candidates to assess if it is safe to omit surgery. The challenge is if we can accurately identify these women after neoadjuvant chemotherapy and before surgery. And to this direction, post-neoadjuvant chemotherapy, large volume image-guided biopsies have shown promising accuracy. This is just one of the studies. This was a large pooled analysis of patient-level data from the Royal Marsden, MD Anderson, and South Korea. And what we found was that if we use a standardized protocol that involves taking at least 6 vacuum-assisted biopsies of a residual imaging abnormality measuring up to 2 centimeters in size, can reliably predict residual cancer with a false negative rate of less than 5%. At the Marsden, we have a small cohort of patients that had a complete response on post-neoadjuvant chemotherapy vacuum biopsy. They then decided not to have surgery and proceed straight to radiotherapy. We have to highlight that this was patient preference and it was not in the context of clinical trial. And at the median follow-up of just above 40 months, there have not been any recurrences. Now, although this is not proof, it just shows that there might be scope further looking into this field of omitting surgery in patients with exceptional response. A number of studies around the world are now actively recruiting patients to assess whether omitting surgery is possible. And the study from MD Anderson very recently reported the preliminary analysis. So at the median follow-up of just approximately 3 years, there have not been any recurrences or progression of disease in women who did not have surgery and proceeded straight to radiotherapy. Therefore, omission of surgery in exceptional responders after neoadjuvant chemotherapy may represent a future direction. Appropriate patient selection is of paramount importance for the success of this approach, but more research is required and results of clinical trials are keenly awaited. And with this, I would like to thank you very much for joining us for this webinar today and happy to take any questions.
That's a great talk, Marius, up to the point, and a great overview of neoadjuvant chemotherapy. It's great to see that there's nearly 600 people online, and there's many questions about where is Ricardo Pardo. Ricardo is on holiday with the family, so he'll be in the next webinar, hopefully, to translate everything to Spanish. Now we have the next speaker, and the next speaker is what we call a serial offender. He has been on those webinars a few times. So we all welcome Andreas Karakatsanis again, and Andreas is one of the surgeons from Uppsala in Sweden, and he's also the co-editor of EJSO, and he's going to talk to us about neoadjuvant endocrine treatment. Andreas.
Thank you very much, Yazan. I will just share my screen. I have to clearly state that I am not a shareholder, but a big fan of iBreast book. So if everybody can listen to me, we can start about discussing about neoadjuvant endocrine therapy. So quite a lot of things that Marius mentioned apply for neoadjuvant endocrine therapy, and I will not go into them. I will just refer to what he said. But more or less, I would say that we are talking about the underdog that in the end may win the day. And when we are talking in general about primary systemic treatment, we are talking about biology-driven rationales to treat patients that will allow us for the assessment of response in vivo, will give us prognostic information based on either path-CR or residual tumor burden, and will allow surgeons for possibilities to de-escalate treatment. However, the facts are a little bit challenging. As Marius showed, the majority of breast cancer are ER positive and not HER2 negative, actually. But the majority of PST research and implementation is on ER negative breast cancer, on basal-like subtypes that are usually HER2 positive and or triple negative. And the explanation is easy. This is what we would call a landmark study, the Cortazar trial from Lancet back in 2014, which showed that pathological complete response is much lower for ER-positive RBB2 negative tumors. And if you go for the low and intermediate grade tumors, it is even lower. In this analysis, we had a 7.5 path-CR for grade 1 to 2, compared to 16.2 for grade 3 luminal tumors, whereas the other numbers are much higher, as you can see. And if we go to more recent data from 2020, the New England Journal of Medicine that Mario showed, the numbers are actually higher, but still, proportionally, we are talking about lower responses. But at the same time, we know that not all ER-positive tumors need chemotherapy, and neoadjuvant endocrine therapy works as well, as you can see in this meta-analysis by Spring and Associates from JAMA Oncology back in 2016, with the limitation of less studies that have discussed this outcome. So if we discuss neoadjuvant endocrine therapy versus adjuvant endocrine therapy, we see that more or less it holds no surprises when it comes to the outcomes of tamoxifen versus aromatase inhibitors or monotherapy versus dual therapy. So the clinical questions in a random order are more or less for whom and what treatment, how long should we go on with that, why are we doing it, and how to monitor it. And if we are to restructure these questions, then we should end to something like that. Why are we doing it, for whom, how long, what treatment, and how will we be monitoring that? So let's take these one at a time. So why? To downsize is possible, and there are quite a lot of observational studies mostly that suggest that you can de-escalate breast surgery and convert a mastectomy to breast conserving surgery if you implement neoadjuvant endocrine therapy. However, what is lacking there is the high evidence data and the consistency of a surgical outcome prospectively, but we will come back to that. If we are discussing about downstaging the axilla in order to de-escalate axillary surgery, then we should probably hold our horses, because what we know from this meta-analysis in JAMA surgery last year, the conversion rate of proven axillary metastatic nodes is only 13%. So if you are hoping that you will avoid an axillary clearance, then perhaps this is not the best way to go, and it's not what you should be aiming at. Selecting the optimal candidate, well, we cannot. I have had numerous discussions with friends and colleagues that are very, very proficient in this matter. One of them is Peter Barry, that I see is in the audience, and I'm sure that he will have more to say in the discussion afterwards. But more or less we cannot. Why? Because we can discuss clinical and biological factors, but I'm going to show you what the problem is. So we are talking about menopausal status, because this is a major determinant of how we will think about endocrine treatment. We will discuss unifocal versus multifocal disease. We will discuss primary tumor size, despite the fact that this is something that's controversial according to evidence, but still it plays a role in our decisions. And then pure invasive cancer versus invasive cancer and DCIS, or mostly in the invasive ductal and non-specific type. And then invasive ductal cancer versus invasive lobular cancer, in the sense that, as Mario showed, the patchy response type, where you have living cancer but lower density in the same extent of the breast, is more usual in invasive lobular cancers. When we look into biomarkers, the established ones are higher ER expression, positive progesterone receptor expression, and lower Ki67 at baseline. From the POETIC trial, we learned that a short treatment of endocrine therapy for 2 to 4 weeks before surgery can learn us a lot, but we are not sure whether this is something that can be implemented in order to select a patient. And while we have obtained very, very important information about how to tailor outcomes in patients that have received neoadjuvant endocrine therapy post-surgery, from the IMPACT and PO24 trial and the TransNeos trial about the use of the PEPI score or the PPEVI score or the ERPA score, and then again the risk recurrence score, the Oncotype DX at baseline and post-treatment, we really are not there in using these markers in order to select the patient that will probably respond to endocrine treatment in the neoadjuvant setting. Some novel biomarkers have shown promising results, but still this is lab data that we need to move to the bedside. So more or less, these are not the droids we are looking for if we are to select the correct patient. A very, very good study that I would recommend to everybody is this from NBJ Breast Cancer that gave us a guide for selection stemming from the combination of evidence and necessity, because this is a study that was done in order to select patients for primary and endocrine therapy during the COVID pandemic. So it was a data combination from a lot of trials, and the authors here could develop an algorithm for postmenopausal women with ER-positive, HER2-negative tumors, and more or less the women were divided in 3 groups. The first group, which is the minority, in the end, we start with the 5% that will be up to 15% after up to 4 months preoperative, 4 weeks of preoperative treatment, are those that are ER positive but should not generally be considered for neoadjuvant endocrine therapy. At the same time, if you see the numbers, I don't know whom we are talking about, but I think that most surgeons and oncologists would not be very happy in discussing the neoadjuvant endocrine therapy approach in patients that are ER positive but not that strongly and more or less progesterone negative. The second group is an intermediate group where the suggestion is that if you've got a Ki-67 at baseline that's more than 15%, you should set a short course of therapy and perform a new biopsy during therapy. If the drop is not generous enough and you have a Ki-67 of more than 10%, then you should probably discontinue therapy so the patient goes to group 1. And the majority, reassuringly, are patients that belong to group 3. These are the strong ER positive and PGR positive patients where you could safely set neoadjuvant endocrine treatment for at least 6 months without being hysterical about very close monitoring. For how long? Well, most of the randomized controlled trials put a 3 to 4 month cutoff, but this is largely arbitrary. So we now know that if you have a patient that belongs to group 3, you could go for at least 6 months because this is where you will start reaping the benefits. I mean, the notion that you could avoid the mastectomy in an ER-positive, HER2-negative tumor that you treat in less than 6 months is at least romantic in my eyes and as far as the data is concerned. In response at 6 months, you could continue until maximal response, but bear in mind that maximal response definition has not been standardized because it has not been looked into in detail. And at the same time, if you discuss more than 12 months in patients that you are performing it with a curative intent, you should proceed with caution because the data is very scarce there. Which agent? Well, we should think standard and start standard. Tamoxifen for premenopausal women and AI for postmenopausal women. For postmenopausal women, the meta-analysis from Spring and Associates suggests that more breast-conserving surgery may be performed because it is a stronger treatment. For premenopausal patients that are tamoxifen tolerant but resistant in terms of therapy outcomes, the notion that you could switch may be intuitive, but it has not been really studied. So these are patients that either should go to surgery, you should either think your options and ask yourself if they are a chemo candidate, and the risk recurrence score can help you with that. And the idea of moving forward to aromatase inhibitors and ovarian suppression may be tested, but this is something that we need to look into a little bit more in the future. We have had very important results in the adjuvant setting with a monarchy trial about CDK4 and 6 inhibitors. But if you look at what has been done in the neoadjuvant setting, in the pilot phase 2 RCT, palbociclib did not increase clinical response when added to aromatase inhibitors. And when if we look at the Lorelei phase 2 RCT back from 2019, tallecilib increased clinical response, but not path-CR when added to AI. And we should bear in mind that tallecilib was quite heavy for most patients in terms of adverse effects. So will the ongoing studies like the NeoMonarch or the DX-CAR-T, will they change something? I'm a little bit suspicious and I'm a little bit dubious. Why is that? Because there are no surgical endpoints in these trials. The problem is this, and we will come back to that in a little bit. How to monitor neoadjuvant endocrine therapy? Well, you should do it as usual. There should not be any difference from what Marios very nicely explained on how to prepare. So you clip the lesion. If you have a node and you're optimistic, then you should clip the node too. You should monitor as you should. MRI is not standard. The US and mammograms suffice. There is an excellent study from the Netherlands that has shown that ultrasound and MRI have the same area under the curve when it comes to monitoring tumors, and especially the luminal A tumors. They follow a concentric shrinkage pattern, which means that they will implode rather than have this scatter patchy pattern response. The clinical examination is very important, not to replace radiological follow-up and monitoring, but to assess possibilities for breast conservation if this is the clinical questions. If you've got response, then you should not do it more often than every other month, because you have to think that endocrine treatment is more like doing yoga, whereas chemotherapy is a little bit of more high intensity interval training, so to say, if one could put it like that. So what do we know? Well, the problem is that there is not much dedicated data or no clear-cut surgical data regarding surgical outcomes for neoadjuvant endocrine therapy, and that is something that we need to be better with. We know that you can downsize and convert a mastectomy to breast-conserving surgery, but this is a convergence of many factors, as we said. And we also know that you probably cannot expect that you will de-escalate every axilla you administer neoadjuvant endocrine therapy to. What would we need? Well, we would need optimally data on fast-track identification of good versus bad response, so that we should give it a trial for 2 to 4 weeks ideally, and then decide on what to do. At the same time, a good way of wishful thinking would be if we had a method of identifying the expected duration of neoadjuvant endocrine treatment, because we need to make sure that the patient does not feel unsafe or tired during this journey. In contrast to chemotherapy, neoadjuvant endocrine therapy does not have a predefined duration, and that may be something that the patients will find cumbersome. And then we need to clarify what to do with the axilla that is still node positive after neoadjuvant endocrine treatment. In this context, axillary clearance is probably unnecessary for low volume disease, but this is not something that you know with certainty. The same way that you do not know if there is a potential benefit from adding chemotherapy in these patients, especially if we think the postmenopausal patients, and if locoregional radiotherapy may suffice. We will probably do it, but is it the way to go in everybody? And in the end, and most importantly, we need to develop a mind frame for neoadjuvant endocrine therapy, since there are less standards when things come to that. My 5 cents. I think that ER-positive, HER2-negative cancer needs our attention. Neoadjuvant endocrine therapy will allow us for better understanding of the complex mechanism and outcome surrogates. Bear in mind that literature suggests that ER-positive, HER2-negative cancer and the effects of endocrine therapy are much more complex than chemotherapy. From a clinical point of view, it is very important to know why you do it and to inform the patient on the duration and the expectations from the very beginning. And despite the fact that the idea is let's give them some letrozole and see what happens, you should avoid an empirical approach to that and identify the evidence and work your way to that. And in the end, you should be annoying, and if you're academically involved, you should involve surgeons in neoadjuvant clinical trials. The meta-analysis that Marios mentioned, that where we saw that 60% of patients that had PathCR received a mastectomy in the end, was a meta-analysis that we had done about some years ago when I was at the Royal Marsden with Marios. And this is where we saw that the potential benefit of using primary systemic therapy as a surgical tool is largely underutilized, and an ongoing update of this meta-analysis that we are doing now is unfortunately not showing any more results. So conscious and awareness and surgeon engagement is paramount in order to reap maximum results. And with that, I would like to thank you.
That's great. Many thanks, Andreas. And it's great to have the first two talks by surgeons and who give some positive hints about oncologists. And now we have a talk by an oncologist. So it's great to see Navita, Sumaya, and many thanks for joining Navita. I know that she's flew back only today. And Navita is going to talk about neoadjuvant radiotherapy. So welcome, and the next 20 minutes are all yours, Navita.
Thanks, Yazan. Sorry, I am a little bit travel weary, so apologies for that. But let me start sharing my screen. But glad I had no, delays at flights. In fact, Scandinavian Airlines preponed my flight rather than, delaying it. So here I am. Right. Let me just. And can everyone see my slides perfectly? Okay, good. Excellent. So thank you for the kind invitation. I suppose I am speaking to majority of surgeons, I guess, yes, with possibly some other oncologists or medical staff joining as well. So my remit was neoadjuvant breast radiotherapy. And of course, you've heard with neoadjuvant chemotherapy, much more established, lots more evidence. And you've just heard from the previous speaker about neoadjuvant endocrine therapy. Again, that's kind of a slightly evidence-free zone, and so is neoadjuvant breast radiotherapy. But I just wanted to take the opportunity in the next 20 minutes to, possibly propose whether this is another way of thinking and another way of, kind of sequencing treatment that may possibly have some benefits. So again, evidence is sparse, but increasingly building in this field. And I'm a clinical oncologist and a clinician scientist, so I'm a team leader at ICR and run a translational breast radiotherapy radiobiology team and a consultant clinical oncologist at the Royal Marsden Hospital. So I've broken my talk into these four kind of outlines. Firstly, just very quickly, discussing the generic advantages possibly of pre-op radiotherapy, then going on to discuss potential indications for pre-op radiotherapy. And here there's a slight bias. Obviously, we've got 2 UK trials that we've been involved with, so I'll give you a little bit more detail on those 2 trials, one published and one completed recruiting. And then, also shared towards the end of the talk about, possibilities of novel translational research, again, with the idea of personalizing treatment for our patients as opposed to a one-size-fits-all. And then finally summarize. So generic advantages, what could be the advantages of doing radiotherapy before surgery? Whereas all of you know, traditionally radiotherapy always happens after the surgeons have removed the tumor, either with breast conserving surgery or a mastectomy. But here is an example where, on the right-hand side is what ends up coming to us radiation oncologists in order to deliver radiotherapy post-operatively. And yes, our surgeons now increasingly place clips, which is fantastic for us to be able to identify the tumor bed. But you can see if you give a bunch of clinical oncologists, radiation oncologists to outline the tumor bed, you get some certain varying volumes there. So there's generally poor consensus, although guidelines can help streamline it, but some include the entire surgical change, some include just the clip, some include seroma, so there's a wide variation. Whereas on the left-hand side, you can see it pre-operatively, obviously the tumor is visible. And therefore, if you were to give radiation oncologists to outline a tumor plus a margin, obviously, there's definitely bound to be more consensus because we can actually see the tumor and there's no other change. Another advantage. Now, again, all of you lovely surgeons do fantastic oncoplastic surgery. You move the tissue around, so the cosmetic outcome is brilliant. But of course, when you put the clips to the tumor bed and then do your oncoplastic surgery, the clips move around, so you might have started off with a 10mm tumor, but post-operatively, there on the right-hand side, you can see the clips are obviously widely spaced. Now that's not 10mm, that's nearly almost 50mm wide, the clips are dispersed over. And when it comes to, again, us radiation oncologists trying to outline the tumor bed for, say, a boost or including it all, it becomes rather, you're increasing more volume or including more volume that you're irradiating, which probably pre-op would have been quite a tight tumor boost. And then some sort of technical challenges of radiotherapy after oncoplastic or implant surgery here. Usually with gravity, when the patient's lying prone, supine for their radiotherapy treatment, the breast tissue falls laterally, allowing sparing of the contralateral breast and heart and lungs. Of course, reconstructed breast sometimes can pose a problem, like you can see here with the implant. And that line there, the yellow line, is showing the posterior border of our field. What if patients have bilateral implants, prophylactic surgeries? Here you can see it's just probably impossible to treat the side you want to treat without actually going through quite a lot of the opposite breast. And if you try to spare the opposite breast, you just end up putting those in the lungs. So these are, I get these are kind of extreme examples sometimes, but nevertheless, some challenges we face in clinic. Now, might doing it pre-op facilitate timely scheduling with surgery? Because modern breast radiotherapy has very much lower acute toxicity than we used to see previously, it enables this kind of thinking that you don't get too, because one of the concerns is obviously that you've got to get radiotherapy acute toxicity, and if the breast is red, erythematous, there's moisture formation, etc., that would not be conducive to doing it preoperatively. However, currently with skin sparing techniques, with the hypofractionation that has reduced the total dose significantly, I hardly see significant acute toxicities in patients. And with IMRT techniques, there's better dose homogeneity, so that all contributes to seeing less acute toxicity. And doing it before surgery may avoid possible delays in starting radiotherapy for wound healing reasons, for example, after surgery. And is neoadjuvant radiotherapy oncologically safe? Now, there's fantastic randomized control evidence for neoadjuvant chemotherapy, isn't it? That neoadjuvant is equivalent to adjuvant chemotherapy, but with the significant added advantage that you're actually delivering it to the breast in situ, tumor in situ, and can get a biological readout whether the tumor is actually sensitive to the chemotherapy, as opposed to just giving 8 cycles blindly after surgery. Similarly, there's no randomized control evidence for neoadjuvant radiotherapy, but conventional treatment sequencing is a historical construct. So the important thing is giving that patient the benefit of all the treatments, so the chemotherapy, radiotherapy, endocrine therapy, and surgery. And retrospective series, this is 2 papers I quote here that suggest comparable local, regional, and overall survival outcomes. And of course, there is evidence for improved local regional recurrence and survival in the case of rectal cancers, where now, chemo-RT has become standard of care pre-op. So is it likely to do so in breast? So what might be the potential indications of pre-op RT in the current standard of care? Now, we, as part of writing this review that was published in EJC now a good few years ago, but in that we discussed potential indications, one being possibly facilitating partial breast or ablative irradiation, facilitating breast reconstruction, possibly downstaging to enable breast conservation, just like neoadjuvant chemotherapy does so beautifully in high-risk patients, and the potential to look at novel drug radiotherapy combinations in high-risk patients, those that don't respond to neoadjuvant chemotherapy so well and still have lots of residual disease after completing systemic treatment. Now, dealing with the first potential indication, which is facilitating partial or ablative breast irradiation. I mean, this would work in patients with low risk breast cancer. So those patients that are suitable for partial breast irradiation, the low grade T1 tumors, non-lobular histologies, for example. So what advantages does pre-op partial breast irradiation have? As I mentioned before, it avoids difficulty of defining tumor bed post-oncoplastic surgery. Typically, treatment volumes are smaller and therefore potentially lower toxicity to the patient from radiation. And the high dose region is obviously removed at surgery. So potentially better cosmesis. So the bit that has been irradiated and potentially can cause late radiotherapy toxicity in terms of induration or fibrosis, etc., you've taken that out at surgery. So you've got what's left is all unirradiated breast tissue. And potential ablative strategies, this is where you give a single very high dose to the tumor, or these should be small tumors, as I said, small T1 tumors. And with a primary radiotherapy is the treatment strategy, and possibly with delayed surgery so that it can continue to shrink. And could we even possibly avoid surgery in these small tumors if you've ablated them with radiotherapy? So I know that's a risky statement to say to a group of 600 odd surgeons here, but potentially that might be an option for patients. So I'm just going to give a few examples of trials in this partial breast irradiation space. There is the Part B trial, which is looking at pre-op accelerated partial breast irradiation, and they've just published in the Red Journal the updated data at 5 years. So this was a multi-center single-arm study based on feasibility. It recruited 133 patients, and they used 2 pre-op radiotherapy doses, either 10 fractions of 4 gray given each day, or 5 fractions of 6 gray. So either a 1 week or 2 week dose of radiation. And they reported outcomes with a median follow-up of 5 years, with really good cosmetic results of 92% at 5 years, with hardly any fibrosis and very low local recurrence rates. Although these are obviously small tumors, they had about 3% at 5 years, and interestingly, 3 of those recurrences were actually in the biopsy track. And since they started excising the biopsy track at time of surgery, there were no more recurrences in the biopsy tract. So that's something to think about, because obviously you're irradiating only partial breast, right? So you're not probably irradiating the entire biopsy tract either. And then an example of the ablative strategy that I was talking about. So this is a trial that Utrecht are running with a 20 gray single fraction using the MR-Linac, a really image-guided conformal radiotherapy where you can see the tumor on the MRI Linac machine. And here they are, it's an interesting strategy. They're delaying surgery to 6 months after completion of radiotherapy, and of course monitoring these patients carefully. And their primary endpoint is PCR. And some preliminary data suggests that they've got some good results there, and we await final results. Now, the second possible indication of facilitating breast reconstruction. This I'm quoting one of my colleagues, Miss Fiona McNeil, who's our head of surgery at the Marsden, where she keeps saying to me, you have your 5 R's of radiotherapy. We have the 3 R's in surgery or plastic surgery, where radiotherapy ruins reconstructions, is the mantra. So regardless of technique, but especially implant-based post-mastectomy radiotherapy is associated with increased complications and possible procedure failures, poorer aesthetic outcomes possibly, and patient satisfaction, and the need for possibly more surgery for revision or implant removal, etc., or salvage afterwards. So can we get away without needing to irradiate the beautifully reconstructed breast that you surgeons have given the patient. Now, if post-mastectomy radiotherapy is indicated, based on the presenting clinical pathological features, then what are the options that patients have currently? They either, they're going to have mastectomy, and that's usually the case after, if they're going for neoadjuvant chemotherapy, which most of these patients, given the size or high risk status, do get. Then mastectomy and radiotherapy is given to the chest wall afterwards, with possibly, no reconstruction. The other two options are the options for some form of reconstruction. And again, number one there is delayed reconstruction. So obviously it does delay the treatment pathway for the patient. The patient has to remain flat-chested for a prolonged, possibly duration of time. The second option there, mastectomy and immediate breast reconstruction, is also open to patients. And it was surprising when our surgeons conducted the survey, even within the UK, there was a rather poor uptake of, or offer of immediate breast reconstruction due to various, either problems or perceived problems with radiotherapy to the, or requirements of radiotherapy post the reconstruction. And then, possible need for revision surgery, etc. afterwards, which was another issue that played on the surgeons and the patient's minds. So in the UK, as a collaboration between the Royal Marsden Hospital and Charing Cross or Imperial College, a third potential way was planned, whereby instead of irradiating the beautiful reconstruction, which is not the target of radiotherapy. I mean, the radiotherapy is being given for potential residual, cancer cells in the chest wall or the skin envelope surrounding that. So to the original breast tissue, not the reconstructed breast tissue. So the plan was to do the radiotherapy to the native breast and chest wall, followed immediately by mastectomy and DEP. Thereby shortening the treatment pathway for the patient substantially. And so the potential benefits were perceived as improved long-term aesthetic outcome, because obviously you've done the radiotherapy before and the recon is happening afterwards. An increase in uptake of immediate breast recon in patients who probably would have been otherwise denied IBR. Could it be more cost effective with a shorter reconstruction journey, reduction in number of procedures, and avoiding delays to radiotherapy because of wound healing issues? So with that, the PRADA trial was set up, testing this as a feasibility and safety trial. It was a non-randomized intervention trial between two centers, with the primary endpoint being the presence of an open breast wound 4 weeks after mastectomy and DEP. And several secondary endpoints there, as you can see, looking at surgical outcomes, aesthetic outcomes, and of course we had a big translational component built into that study as well. Now, what were the results? We were delighted that this paper got accepted and published in the Lancet Oncology in May this year. We recruited 33 patients. It was radiotherapy to the whole breast and or lymph node regions as was needed, as was predicted or based on original clinical pathological findings. I can probably come back to that in a second later, but this trial definitely showed that autologous free flap surgery is feasible and technically safe if performed within 6 weeks of preoperative radiotherapy. So here the radiotherapy lasted about 3 weeks, sandwiched between neoadjuvant chemotherapy and surgery, and surgery was done anywhere between 2 to 6 weeks following completion of radiotherapy. There was also, it was shown that, pre-op RT can reduce treatment pathway delays that might occur with post-mastectomy radiotherapy due to wound healing issues, and it showed high aesthetic outcomes. This is courtesy Dan Leff, who's one of our surgical colleagues at Charing Cross Imperial College, where he's now compared the PRADA cohort with historical controls, those who had the standard pathway of a mastectomy and radiotherapy afterwards. And he's found that, on average, there's an advantage to the neoadjuvant radiotherapy pathway of 38.5 days versus, if you're giving radiotherapy post surgery. And he also looked comparing the PRADA cohort with, again, historical controls based on surgical safety. And again, there's no real difference to all these surgical complications that might be perceived as problems. And then comparison with breast satisfaction. This is Amy Godden's work, where, again, looking at historical controls, finding that the PRADA approach seemed to have better cosmetic satisfaction amongst patients. Right, now this is where the slight complication when we try and do the neoadjuvant radiotherapy is, and I think the previous speaker also alluded to it in the NET situation, where, I think indications for breast or chest wall radiotherapy, you can always almost get consensus before surgery for that, whether there's need for post-mastectomy radiotherapy based on size, spread, breast anatomy, small breasts, etc. But it's the axilla that becomes slightly complicated. If it's node negative at diagnosis and you perform an SLNB, the negative, then of course they don't need any further axillary treatment. It becomes fairly straightforward for us radiation oncologists as well to say we'll just give chest wall breast radiotherapy before the surgery. After neoadjuvant chemotherapy, if they're clinically node negative, then we would want to do a sentinel lymph node biopsy before we decide on a radiotherapy treatment fields, just because it is very difficult with our modern radiotherapy, with our arcing techniques and various things, to go back and match nodal fields. That becomes really problematic. You run the risk of overlap, you run the risk of geographic misses, etc. So we want to know for sure before we deliver radiotherapy, because all of it needs to be decided and given beforehand. So it does mean that these patients do need a second operation, if you like, a sentinel lymph node procedure before radiotherapy and then their final surgery. And what about node positive patients? Now, most of these patients actually fall into this category because they're high risk, have been given neoadjuvant chemotherapy, and majority are node positive as a consequence of that, or result of being high risk and advanced. And now if they are node positive after, or remain node positive after neoadjuvant chemotherapy, then it's more than likely standard procedure would be offering them axillary nodal clearance following at the time of surgery. And therefore we would then, at least in PRADA, this is what we did. We did the radiotherapy and included the undissected axilla and also the IMC in quite almost a one-third of patients in PRADA received IMC radiation as well, again, because you can't go back and do that. If they are node negative after neoadjuvant chemotherapy, again, you need an SLNB procedure or a targeted axillary dissection, and general consensus was you irradiate the axilla plus minus the IMC. Now, there could be a potential problem here where you overtreat with radiotherapy to the nodal regions, whereas if you had complete clear pathological evidence, you obviously tailor it to that. So there are, some areas that we do still need to think about a bit more carefully in this kind of approach. Now, the third bit, facilitating breast conserving surgery with neoadjuvant chemotherapy. As I said, that's standard of care now, but we do know that some subtypes do not respond well to neoadjuvant chemotherapy, and the key subgroup here or phenotype here is the strong ER positive patients. So, in strong ER positive patients that are grade 1, 2s, for example, if they are large, they present with big tumors, and that would preclude doing conservation surgery. We can't give them neoadjuvant chemo because we know they respond rather poorly to it. And so one of the possible thoughts is that whether if we gave neoadjuvant radiotherapy, could we downsize this and enable conservation? So with that, the NEORT trial was set up in the UK. This is led by Charlotte Cole at Cambridge, and is a collaboration with Cambridge and ourselves at the Marsden ICR, to test the feasibility of neoadjuvant radiotherapy, followed by 20 weeks of neoadjuvant endocrine therapy before surgery. And so the primary endpoint is, of course, it's a feasibility one, so it's a proportion of patients successfully completing this, followed by breast surgery as per study protocol, and various secondary endpoints looking at surgical complications and breast conservation rates, toxicities, both acute and late with radiotherapy. Now, again, as I said, these are the ones that you wouldn't give neoadjuvant chemo to, so HER2 negative, ER positives, grade 1s, 2s. And here again, it's to the whole breast, and they all needed a central lymph node biopsy beforehand if they were clinically or on ultrasound node negative before radiotherapy started. And as I said, they had 20 weeks of endocrine therapy as well, allowing that tumor shrinkage before surgery. Now, 14 out of the 20 patients in the trial were recruited and study closed. This was affected by COVID, and therefore the decision was made to sort of close it early, slightly prematurely, because of the need for that central lymph node procedure and theatre time availability during COVID. So the results are pending. Hopefully we should be able to share it with you soon. And then the final possible indication for neoadjuvant radiotherapy is the the possibility of combining novel drugs and radiotherapy combinations in high-risk patients. Now, window of opportunity trials have been very successful with systemic therapies, but there are hardly any in the radiotherapy realm. And here, because the breast tumor is still in situ, bearing in mind, all adjuvant radiotherapy is given to microscopic disease, right? Here, if we're doing it neoadjuvantly, you're actually irradiating the breast in situ. So it allows harnessing any synergy between radiotherapy and drug with the tumor still there. And there are several now trials ongoing, about 10 odd that are there on clinicaltrials.gov, looking at various different drug combinations, including PARP inhibitors, and a lot now in the immune oncology realm, looking at radiation as in situ vaccine, including checkpoint inhibitors, etc. Especially in these, where we know that if they haven't responded to chemotherapy, for example, not achieving a PAT CR does impact on a long-term outcome and overall survival. So it is in these high-risk women that this sort of strategy would be quite important one to investigate. So just very quickly, this is sort of two things that my lab is researching on, looking at high-risk breast cancers, whether you can modify the immune response with neoadjuvant radiotherapy strategies, just with radiotherapy alone, or then adding an IO agent to radiotherapy. And in these large advanced tumors, the hypoxia is also a problem that causes radioresistance and poor prognosis independent of treatment, and whether drugs targeting that in that space can also impact. And of course, it allows various response monitoring treatments to be, or imaging modalities to be looked at, radiomics, for example, to be able to predict radiation sensitivity and then feed back to the next generation of trials. So just wanted to make a really quick plug at the end for this trial that is currently recruiting in UK and with 2 centres in India. But this is just for the UK colleagues who might be on the call, or possibly Indian colleagues on the call, testing intratumoral hydrogen peroxide as a radiation sensitizer in locally advanced breast cancers. And it is harnessing all these various modes of action of hydrogen peroxide, including breaking down to oxygen and reoxygenation alongside the radiotherapy to improve and sensitize radiation. And it is given under ultrasound guidance, you can see here. So these are just some fantastic results we've got with the phase 1 trial, with complete responses and the waterfall plot on ultrasound measurements showing that 50 to 100% complete response rates in a phase 1 trial, which is, although it's not randomized, but it is encouraging. And so we've got 35 patients recruited, and I just wanted to flag to the UK colleagues here that these are the 6 centres in the UK that are up and running. We're open for referrals. So please do contact me, and we do have 2 to possibly 3 centres in India that will be opening soon. The Tata Memorial in Calcutta is already open. So this might be, although this is in the locally advanced setting, it is still before surgery. And just novel translational research, just the last slide here, provides a unique opportunity to study the effect of radiotherapy with the breast in the patient, identifying biomarkers of response. And it's important for developing personalized treatment strategies in this group of patients, because it allows pre and post RT biopsies, etc. So pre-op RT summary. There is obviously a paucity of high quality data in this area, but pre-op RT certainly may have a future role, prior to breast reconstruction as a possible tool to downstaging to enable breast cancer conservation surgery, partial breast radiation for low risk and ablative strategies, enable novel drug combinations, and last but not the least, enable translational research. And those are my acknowledgements, and I'll stop there and open for questions.
That's great. Many thanks for the lovely talk, Navita. Now we'll go for the discussion. And so, yeah.
Yazan, you are muted.
Am I talking to myself for the past 5 minutes? Am I? That's great. So even after so many webinars, we still can't get it wrong. So it's great talk, Navita, and many thanks for a lovely overview. And it's now time for the discussion. There's about 40-something questions on the Q&A section that we'll go through. And it's great to have Prof. Ahmad Tariq Awad from Egypt, Prof. Sana Al-Sukhan from Jordan. We have Rachel O'Connell from London, and Ash Kotari also from London. Now, I think the easiest thing is to go through things step by step. So we'll start with the neoadjuvant chemotherapy. I have people asking me, why are you getting surgeons to talk about neoadjuvant chemotherapy and endocrine treatment? Because we can always listen to lovely talks from oncologists, and we have always listened to lovely talks from oncologists. But if we want surgeons to change their mindset and change their practice, we need surgeons also to talk about this. And that's why we got Marios and Andreas to talk about that. Now,
congrats, yes, and I'm really impressed. The first time in my life to see surgeons advocating for neoadjuvant therapy, being patient with their knives and talking. I mean, you guys are really smart with the knives, but to really think before the knife, and actually wonderful job. All the surgeons have done a great job, great talks. I've seen actually some of my colleagues here also thinking that way. This is a mind shift. Congrats.
Thank you. So we'll start with the basics of neoadjuvant chemotherapy. There's many questions that are on the system asking, for example, how do you monitor? What's the regime? And I would say there's different regimes in different parts of the world. The key thing is when you're talking about complete pathological response, especially for the HER2 positive tumors, we're talking about optimal treatment with optimal chemotherapy. So if you don't have all the chemotherapeutic agents, you're not likely to get that type of response. And people are asking about how to monitor. So any comments from, let's say, from Prof. Awad, how do you monitor your chemotherapy patients? What sort of imaging do you use in Egypt? And Sana, what sort of imaging do you use in Jordan to monitor neoadjuvant chemotherapy patients?
Okay, you know, Yazan, you're actually discussing my favorite topic since I was in my fellowship. Over the years, I've talked about neoadjuvant treatment, advocated for that. And guess what? The simplest way to monitor your patient, wherever you are, and when you're giving neoadjuvant therapy, is clinical exam. And you would think that I was with Ash last week in a webinar, and I was talking about, you know, choosing wisely and attention to resources. I'm not doing this because I'm in an area of limited resources. We have so many radiologists. My colleague will be happy to follow for me. But guess what? Actually, I'm going to be quoting our colleagues from Germany. I don't see any from here. You know, the German group have done the Sexto trial, where they indeed randomized patients to neoadjuvant therapy with 6 cycles of chemotherapy. It's a complicated design, but after 2 cycles, and this is like 10 years ago, after 2 cycles of treatment, if the patient has good clinical response, they would continue on to complete the 6 cycles as planned. If they are not, they are randomized to either continue the same treatment plan or go on to a different regimen. And guess what, Yazan? The Germans have demonstrated that clinical response to the first 2 cycles are excellent prediction for not only, you know, the outcome, but even response. So it's not only prognostic, it's predictive. So if you can actually examine your patient, that's more than enough for response. Of course, there are caveats to this. Before planning surgery, probably you do need to repeat imaging. I usually repeat imaging only before surgery. I do not keep on doing ultrasound or, you know, MRI or mammogram, sophisticated imaging all through. I just choose to do that specific imaging for objective assessment right before we plan surgery, because to help you guys plan your surgery better. Otherwise, clinical exam. And I switch, by the way, the regimen based on the German data.
I agree, and many centers here in the UK mid-cycle, because we usually do images before, images after the third cycle, or mid-cycle, and images after. But some centers say there's no role now for the images midway through, as long as there's some clinical examination to show that they're not progressing. So some people have started omitting that. Any comments, Prof. Awad, because you have your hand up?
Yeah, please. It's very nice talk. I enjoyed all the speakers, and I congratulate them for their esteemed presentations. Actually, as Dr. Sana told us, the presentation with the clinical examination after doing the proper imaging, whatever you do to delineate the proper tumor, whether mammography or MRI, you use it in Egypt. However, and I usually tend to follow up my patients during the chemotherapy. I don't send my patient to the oncologist and tell him, I'll see you at surgery. Definitely, I follow up and monitor the response in the mid-cycles. Dr. Sana told us that in the first 2 cycles, they are going to observe the response. But sometimes, this is a very important question that I want to raise it here. Sometimes we shift, sometimes we give anthracyclines, then shift to taxanes, and sometimes there is no response from the start. And the second cycles with taxanes are going to be very beneficial to the patients. So when do you decide that there is no response to these patients? And if there is no response to the patients, do you do surgery? You shift them for surgery, and if the patient is operable, or you use a second-line treatment.
And Ravi, do you want to take that? So is there any time? Oh, sorry, Navita also has her hand up. Any time that when do you shift and you bail out early when you're doing your chemotherapy?
Well, is Ravi answering? I mean, I can.
No, Navita, go ahead.
But then yes, Ravi can give his perspective afterwards. No, it is. I think I agree. I mean, you know, when resources are limited, etc., then definitely clinical examination is the simplest thing you can do, but carefully. But also one caveat to clinical examination, I just say that it does need a degree of experience. So if you've got junior colleagues following up, then there is a little bit of a potential problem. And I think with clinical examination, if it's the same surgeon or same oncologist assessing through, it definitely improves your accuracy of determining, whether it's responding or not. Because, in my clinic, we have juniors and seniors, and the experience is different. So that's just the one caveat about clinical examination, but definitely all in favor of it. And the other simple exam is an ultrasound, again, which is widely available.
Very good.
We don't routinely do MRIs. They are more expensive. They're, like not all centers have access to it, but we'd reserve MRIs for certain slightly complicated patients, that are difficult to assess on ultrasound, for example. But just in response to your question about when do you bail out, and this is, quite commonly, and I see it often in these triple negative patients sometimes, that don't respond to EC, are very, chemo resistant, and then you've got to switch early to a carboplatin, a paclitaxel, or a platinum-based and taxane-based treatment. So often we will always do some form of objective response imaging, ultrasound, or if chose an MRI, then MRI after 2 cycles of EC, before we decide, whether if there's clear progression, there's no point continuing with EC. So we would switch and give the benefit of a platinum-based treatment, or in HER2 positive patients, a HER2 positive and taxane combination, because generally we start with anthracyclines and then move on to the second regimen. And often triple negative and HER2 positives is the second regimen that is more effective potentially than anthracycline. So it's a good idea to switch to your more effective regimen, and then we give 2 cycles of that with image. And if there are in a minority of these really resistant triple negatives, for example, that don't respond to that either, then we bail and get surgery going quickly. But the key would be to discuss that patient back in your MDT when you are worried they aren't responding, so the surgeons are already on board and can kind of review the patient early on, so there's no delay when you're kind of stopping chemo and switching to surgery. So I think it's a multidisciplinary team approach for these patients, and I'll stop there.
That's great. Thank you, Navita. Before we go back to you, Sana, Ravi, any comments on that?
So, whilst completely agreeing with Navita, I want to go one step further. We don't even have junior doctors following up our patients now, and most of our clinics are nurse-led clinics. So the reliability of an accurate clinical assessment after every cycle drops even further, and the continuity of nursing care is also what shall I say? It's short. So whilst MR is underserved generally in the northeast of Scotland, MR is also reserved for when you start the treatment and after the treatment, after 6 cycles of treatment. And this may very well tie in with how some of the radiology resource, a clinical radiology resource in the form of ultrasound fits in, and there is more availability of that, and there is more objective response assessment with that. And we do 3 and 3 for most chemotherapy, for most neoadjuvant chemotherapy patients. I mean, Aberdeen was the center that did the anthracycline tank switch. The study was published in 2001, so it is very established here. And going back to the more effective treatment strategies in the HER2 positive cancers, I think having objective response where there is discordance becomes important, and you need radiological correlation with that. So yes, whilst agreeing clinical examination adds a lot, I think with a touch of caveats, it is not applicable to every center. Staffing is the key.
Before we go back to you, Sana, I know that Rachel has been giving up her time during her holiday and might need to leave a bit early, and also Ash might need to leave a bit early, otherwise he'll be lonely and divorced soon. So let's go to Ash and Rachel. So Rachel,
let's go to Rachel first.
Let's go to Rachel first. Let's talk about MRI scan imaging and planning surgery. What do you use in the Marsden? You usually plan your surgery post chemotherapy.
Yeah, so at the Marsden, I'm sure Marios can chip in, and also I know Peter's on the line as well. We tend to use ultrasound. When there's complex imaging, a decision may be made at the time of diagnosis for an MRI. And then I think this is where the importance of the MDT comes in, that a decision is made during the MDT that, yes, we think an MRI might be needed later on in the chemotherapy to help with monitoring and surgical planning. But usually we just use ultrasound, and we find that to be really effective. And one of the things that Peter has been a real advocate for marking lymph nodes with mag seed. So that obviously has a bit of a scatter if you're using MRI. So usually we find ultrasound to be a really good way to monitor the patients. One of the things that I've had with a couple of patients is actually where patients who have kind of reluctantly had neoadjuvant chemotherapy, and they've had a great response, and they've got nothing found on imaging, a complete radiological response. In fact, have had their surgery before completing all of their chemotherapy, because they don't particularly want to have all of their chemotherapy because of, family issues. I've had a young mum who didn't really want to continue with the neoadjuvant chemotherapy if they could. So we went along with surgery before she'd completed her chemotherapy, on the basis that if she had a complete pathological response, she wouldn't need any further chemotherapy. And she did. So she actually got away with having less chemotherapy than perhaps she would have done. One of the things I think is really important is to do a mammogram before the surgery, particularly if you've got calcifications. So I think Marius was talking about that, to monitor the calcifications with a mammogram, because you can keep doing ultrasounds, but it's important to remember to monitor the calcifications as well.
That's great. Many thanks. And Ash, any comments how you do it in guys?
Well, guys, unfortunately, we still use MRI scan, although I totally agree with the entire panel. I've been arguing for years about the use of MRI scan, but I think since we have lots of juniors online, whatever modality you use to start off with, stick with that modality. Don't switch. Don't go from ultrasound to MRI scan to back to MRI scan and ultrasound scan and mammogram. MRI scans obviously have a role in planning complex oncoplastic surgery, so that is a totally different set if you're trying to do it in multifocal, multicentric breast cancers. If you're trying to do something heroic, yes, by all means, MRI scan, and then at the end you plan your surgery based on MRI scans. But it's important that we make the point, and Andreas makes this point every time, is MRI scan doesn't reduce re-excision rates. It doesn't reduce your mastectomy rates. In fact, it increases your mastectomy rates. So for all those people who require MRI scans to tell them how well the patient is responding, I think I take all your points. A good clinical examination is what is required, because you have to also bear in mind that 3 to 4% of these patients will progress on chemotherapy, and you don't want to miss their boat of operability. So you need to be sure that these patients, they're looked after. And Ravi, we have to be politically correct. So the nurses are also going to do a great job in assessing all of this. But whoever assesses them has to assess them, has to be clinically apt. The other thing is, when you're doing neoadjuvant chemotherapy or anything neoadjuvant, is you have to have a defined goal. So most people give neoadjuvant chemotherapy thinking it's great, but always, like you say, the MDT needs to decide what is the role, what is the aim of neoadjuvant chemotherapy. Is it because we are going to get a complete pathological response? Is it because we're going to downsize the tumor? Is it because it's locally advanced breast cancer that we want to make it operable? We need to have the remit, and please have a plan that we are going to give neoadjuvant chemotherapy with a view to breast conservations, or this patient still needs a mastectomy. And just one last point before I run away is, we make a great deal about microcalcifications, but let me tell you, microcalcifications are dead cancer cells. The cancer cells are around the microcalcification. They're not the microcalcification. Microcalcification are actually tombstones. You're looking for the live souls around that tombstone. So focusing on microcalcifications always is not the right thing. And even if they disappear, do they disappear? HER2 positive, we have a paper published in which, yes, we had HER2 positive microcalcifications disappear, 10 patients, but that doesn't make a huge series. So yes, if you have microcalcifications, as Navita says, please do a mammogram and look at the footprint of disease. If it has changed, if you want to biopsy, as Mario said, not all microcalcifications are cancerous. If you have proven that the microcalcifications before neoadjuvant chemotherapy were cancerous, by all means, if you want to do more heroic surgery, you can biopsy them after. Do a nice vacuum-assisted biopsy and establish what those microcalcifications are. So there is a lot, even although it sounds very simple, and these great speakers have made it sound very simple, there is a lot of planning and lots of MDT, discussion that goes into successful to get those results that Mario showed post neoadjuvant chemotherapy. There's a lot of planning that happens. There's a lot of discussion and patient involvement that happens. And I don't think we should forget that.
That's great. Many thanks, Ash. Before we switch to neoadjuvant endocrine, we need to talk about a couple of things on the adjuvant chemotherapy. And yes, I love that you brought the point of microcalcification, because sometimes post chemotherapy, I say, do we really need to do a mastectomy for this lady? And if I talk about microcalcifications, everybody look at me as if I'm a mad person in the MDT. So it's great to describe them as tombs.
There's nothing new in that, Azan.
Yeah, I know. Some things don't change. So, Prof. Awad, do you want to comment on that? You have your hand up.
Yeah. The microcalcification is a very difficult issue, I think. When I'm dealing with a patient having microcalcification confined to the tumor, this is an easy job, I think. However, if I have an extending outside the tumor and still they are persistent, am I allowed not to remove them and only rely on the biopsy to whether to justify to remove or not to remove? Actually, how much the false negative result I'm going to have in such a situation.
So, for example, Marius, if we change the question and let's say we have some of the patients that are included in your trial that had complete response, but they still have microcalcifications, will they be considered for large volume biopsies of the residual radiological abnormality to assess if they need to surgery or not?
At the moment, when we are using vacuum biopsy to predict the residual cancer, we are not including women who have microcalcification extending beyond the main tumor. But that's kind of a separate issue. We're now not discussing about predicting pathologic complete response with a possibility to avoid surgery in the future. We're discussing about personalizing and planning surgery. So I would say that for these women, depending on the extent of the microcalcification and the tumor biology, I would do vacuum biopsies to see whether there is residual cancer or not. Because if it's HER2 positive disease, then we know that the pathologic complete response rate is extremely high. If it's a luminal layer cancer, we do not expect that there's going to be a complete response, in which case you just need to do biopsies. That's what I would do to assess how much of this extent of the disease is still cancer cells or not. And if it is cancer cells, then the answer is clear. We just need to excise the footprint. If it is not, then shared decision-making comes into play. Multidisciplinary discussion and shared decision-making with the patient to discuss the uncertainties, the benefits, shared decision, manage expectations, and then proceed. Understanding that there might be more positive margins, for example, there might be need for more surgery. As I said, it might sound simple, but it's very complex. These are very complex cases and require a lot of multidisciplinary discussion and also involving the patients. But I would say it depends on biology and it depends on what we are trying to achieve.
That's great. Sana, you had your hand up a couple of times.
Yeah, actually, brilliant comments from brilliant surgeon. Ash did it, summarized most of the points I wanted to raise very nicely, especially like start with a modality and continue with the same, because MRI usually comes up with new findings all the time. And most of the time you end up doing mastectomy if you do MRI, especially if you do it after the neoadjuvant therapy, because you are bound to find something else. The thing that actually I'd like to raise as a medical oncologist among you all, when you have progression on the first line treatment, do not rush to do surgery, because you might do surgery true, but those patients are usually the ones that end up having a very bad local recurrence that we really don't know what to do with. It's very good if you can identify some type of response to some regimen and then send the patient to surgery. Yes, you have to be with your colleague. I mean, you have to discuss with your colleague, patient progress, can I try another line? Because most of the time, those who progress on all lines of treatment, they end up having very ugly local recurrence. And this is one of the most difficult dilemmas for us to talk about.
That's great. And welcome, Peter Barry. Peter was with us, with the audience, and we put Peter up with us. Peter is one of the other consultants in the Marsden. So we have exactly 50% of Marsden panel today, which is great to have you all. And Peter had a very good comment on the chat function. He said one of the least resources is experienced clinicians. Am I correct in saying that, Peter?
Yes, I didn't know that anyone would read that comment, but thank you. Firstly, great session, great speakers. I really enjoyed them all. I feel like an interloper. Yeah, look, it does worry me that sometimes our medical oncology colleagues, that there are different people assessing patients at different time points. And the worst cases I've seen, and I think Ash Kathari has alluded to this as well, that, the worst case I've seen it was when, juniors sort of say, well, there might be some progression, but let's see how you go next time, and then someone else sees them. I think if there's any doubt, please refer them back to the surgical team, because, I really want to see that patient. And frankly, these are the patients that I, as a consultant, want to see, because ultimately the final surgical decision, sure, it's up to the patient as well, but it really is up to what we can do and feel we can achieve for the patient. So I think we do have to be involved closely. The other thing I would say is that ultrasound is now fast becoming, I would think, a surgical tool. I personally do my own ultrasounds, but I still find the axilla challenging. And I think one thing we haven't focused much on, which is maybe reasonable, is doing neoadjuvant chemo for axillary conservation. And in a lot of women, that's a big priority. It's not just the mastectomy issue, but it's the functional issues of the sequelae of axillary surgery. So let's not diminish the importance of trying to get a complete response of the axilla, even if we still maybe think the patient will always need a mastectomy. Maybe we can downstage the axilla and reduce the extent of surgery. So I think that's another reasonable indication. I think all the other comments have been dealt with very nicely.
That's good. And the question and answer section, that was one of the questions that was asked. What's the response rate in the axilla post neoadjuvant chemotherapy? It really depends on the biology. And on many occasions, we give neoadjuvant chemotherapy to do a targeted dissection to try to conserve the axilla, which is a great thing to do. I think axillary surgery is a medieval operation that at one stage we'll get rid of. And at what stage we'll see when we really need to stage the axilla. Now, we need to go to the second thing. Now we need to go to neoadjuvant endocrine. We've talked quite a bit about the neoadjuvant chemotherapy. And there's the ugly duckling, I call it, always the neoadjuvant endocrine. It's mainly, not many people will give it because it does not does not give you lots of complete pathological response. You nearly never hear of it. It does not, the patients do not respond quickly, and people are a bit nervous about giving neoadjuvant endocrine, but we're not always looking for a PCR. Sometimes we're just looking for to downstage the tumor to get more, and sometimes you just want to understand the biology. So Andreas, we've been boring you for the past 15 minutes. Do you want to comment?
No, just before commenting, thank you for bringing Peter Barry on, because he's a soulmate. We think alike, and his knowledge on neoadjuvant endocrine therapy is unparalleled, so he will contribute with that. There are some questions that I would like to answer live. And the first one was the importance of downstaging tumor in the oncoplastic era, and whether it is wise to give a patient with a luminal A disease neoadjuvant chemotherapy so that you might give time for resistant cells to metastasize. So in regards with that, there is observational research that suggests that surgery post-neoadjuvant therapy, regardless of whether it is chemo or endocrine therapy, comes with less complication and less re-excisions. On the other hand, Marius made a very, very fair point. I have to lift it. The importance of de-escalation of the complexity of breast conservation. And I feel that I have a say in that, as I am somebody who is leading, and with very good colleagues, a unit that does 90% breast conserving surgery with 5% re-excision. So if we can de-escalate, then the reasonable thing is to de-escalate. The other thing is that regarding chemotherapy for the luminal A tumors, I think that the literature I presented and a lot of other studies are quite convincing about the fact it is crucial to identify biology. Another question that I got is, what is the role of genomic signatures for neoadjuvant endocrine therapy? So I showed it briefly, but these are not the droids we are looking for. Why is that? Because these tools, and mainly recurrence scores, can help us to understand what patients that we think are luminal A are actually high-risk patients that will benefit from chemotherapy, and in that setting, you could give it neoadjuvant. But they cannot tell you, a low-risk score will not necessarily tell you that this patient will respond adequately in terms of clinical response to neoadjuvant endocrine therapy, nor will they tell you that this tumor will shrink faster. There is a big paucity of data in this matter, and this is a very, very important key component when it comes to these patients. Then the other puzzle that we were discussing with Giuseppe Catanuto during the webinar is what Peter will also tell you, the pre and perimenopausal women and the choice of the regime, because there was another question, why not do it for everybody? Why not give TAM or, ovarial suppression with an aromatase inhibitor? Regarding TAM, I would not be very constrictive with that, but I do not know how much information do we have the time to get within 2 to 4 weeks, and whether it will change things enough for us to modify surgical planning. That's the one thing. The other thing is that I would be very, very cautious with the idea of ovarial suppression and aromatase inhibitors in premenopausal women, because for starters, a short cure will not probably give you any clinical effect. And on the other hand, if this is a lady that does not need it, then it is by definition overtreatment. So we should not go into that. I think that it is very, very important to avoid the why or why not approach. What I said in my talk, give her a little bit of letrozole and we'll see how that goes. You need to have a plan, and you need to have worked for that plan. That's my take, more or less. And I would really like to hear what Marius and Peter have to say about that as surgeons, because I know that they are surgeons that really tailor their surgery to tumor response.
Marius, do you want to go first?
Yeah, so my experience, limited, anecdotal, I do not have data to support, is that neoadjuvant tamoxifen is not particularly helpful, especially for a short period of time. We do not expect to see great response in premenopausal women with tamoxifen to change the size of the tumor and allow less complex or less conserving surgery if they needed the mastectomy. As Andrea said, AI and ovarian suppression, although an option, I think might be over-treatment, especially for a woman that might not need it if they are, for example, node negative, which is the main indication to get AI and ovarian suppression. So I would be very cautious to kind of implement this approach. I have used tamoxifen in the neoadjuvant setting for women that really want to work hard to try to avoid the mastectomy, although I canceled them. And again, it's to manage expectations that I did not think in the end it would work. So we need to be careful during the consultation, explain what we expect to happen, what is the potential benefit that we want to gain, and then tailor treatment accordingly. Also, yeah, I mean, apart from the window of opportunity trials that we use, for example, AI for a short period of time, and then we assess Ki67 changes and potentially try to predict response to treatment, we would probably need to give endocrine therapy for a period of months before we can see any meaningful response to allow really change in surgical planning. So, yeah, this is my practice and how I can interpret the existing literature. Would really love to kind of listen to Peter's views as well, who is very experienced in this field.
So let's listen to Peter, and then also if you listen to Rachel, then we have the three Marsden surgeons' view from that point of view, and then we'll go back to Sana, because Sana, and you had a lovely description of how you use the Ki67 in the webinar last week. So Peter first.
The three musketeers. I think, first of all, premenopausal, perimenopausal, and TAM, for me, it's more of a temporizing measure. If I think there are going to be delays with surgery, then sometimes it's a psychologically good thing for women. And don't forget that, you know, if you're going to do OFS with TAM, you need at least, you know, a couple of weeks of TAM. I mean, TAM really needs about 6 weeks to, you know, reach its steady state. But, you know, potentially after a couple of weeks of TAM, you could then give, you know, Zoladex, but then you need the second dose of Zoladex before you can stop the TAM if you want to stop it before surgery. So it's not simple, firstly. So secondly, you know, so I think I use it more for temporizing rather than to try and get a clinical response. There's very little data on this area. It's really data-free zone. And I think, therefore, it's, you know, ripe for clinical trials. So I'd say that. Yeah, and then the other thing is that what I get a lot of second opinions from outside. Just a very quick comment on the younger women, and a lot of them have got luminal B, so they're sort of maybe moderately positive, PGR negative, grade 3, say. And so remember, when we talk about luminal A, luminal B, 99% of us don't have the intrinsic subtype, so we have to invent proxy or surrogate markers for what we think is luminal B. We know it's not entirely accurate, but it's not a bad approximation. So for those women, I think, who are luminal B and maybe a node positive and want to downstage the axilla, you know, I think probably for those, we see at the Marsden, for example, a 25% PCR rate in the axilla, I'm talking about axilla only, for, you know, what we would call sort of, in quotes, luminal B disease. So I think also, let's not underutilize chemotherapy where it may be of some benefit, perhaps more in the axilla than the breast, but even get an idea about the responsiveness, you know, pre-surgery. Again, not aiming for a complete response, although in the axilla, I would argue you could. In that 20-25% of women. So again, look at what the priorities of the woman are and, you know, what you think is achievable in the discussion. I'll leave it at that. Thanks, Yeza.
That's great. Rachel, any comments?
Just two little comments, really. I haven't really used tamoxifen a lot as a neoadjuvant approach. I've had a couple of patients. One thing I would say is probably worthwhile discussing it in the MDT, again, multidisciplinary working, because oncologists may want to do an oncotype on the specimen as well, that's removed. And obviously they can't do that if the patient's had tamoxifen. You can obviously do it on the core biopsy, but again, you need to speak to your pathologist and make sure you've got enough material to do an oncotype on the core biopsy. So that's one thing that I'm quite cautious with. And then the second thing is obviously there's always the worry about deep vein thrombosis risk, particularly if the patient's going to be having major surgery such as a DEP reconstruction. Now, I know there was a recent systematic review indicating the safety of having a patient on tamoxifen before they have a DEP reconstruction, but I think it's something that does make me a little bit nervous. So yeah, I think just discussing it in your multidisciplinary team meetings really important, just to get the perspectives from the medical oncologists and about what they think the sort of long-term plan and need for adjuvant chemotherapy will be.
Before we go to the neoadjuvant radiotherapy in the last session, any comment about Ki-67, Sana, before we go to the neoadjuvant radiotherapy?
Actually, yes, and to me, the neoadjuvant setting is definitely an in vivo sensitivity test for my treatment. Let's make the distinction between a postmenopausal and premenopausal lady. Postmenopausal, yes, I'm willing to actually, even if it's a large tumor, go all the way for even beyond 6 months if there is response, and usually at least the inoperable can go operable, and even, you can go to breast conserving surgery with prolonged treatment in a postmenopausal lady. So yes, even with endocrine therapy, you can preserve, but you really have to be in it for the long run. It's not a matter of 1, 2, 3 months. As long as there is response, guaranteed follow-up, your patient is followed. Yes, I do that. Now, the more tricky part is when you have that patient, younger patient, ER positive, PR positive, strongly positive, the Ki-67 is bordering around 20%. Yes, you have the luxury of testing for Oncotype DX, but if your patient does not have access to that, I think that, you guys in the Royal Marsden did the POET trial. I would give a couple of weeks of neoadjuvant treatment, assess the Ki-67 on the post-therapy, post-therapy surgical specimen, and this can tell me if she can get away with only chemotherapy with only endocrine therapy as opposed to the need for more aggressive regimen. I mean, if there is a significant drop, less than 10%, I'm quite reassured for that lady, especially those that are, perimenopausal, like in their 40s, and node negative. If the Ki-67 drops to less than 10%, I feel very assured to carry on with only endocrine therapy. So that's how I use it. I use it for the 2 weeks period. And I think that window period is quite informative for me as a clinician. Now, if the Ki-67 doesn't drop, that's where the tricky part is. You look at all other features and, you have the CTS score and other stuff to discuss with your patient, the need for adjuvant therapy. So I never shy away from 2 weeks of neoadjuvant therapy. And by the way, my colleague surgeons usually are always scared of the tamoxifen DVT risk, which I believe is overrated,
So that's great. I think before we go to the neoadjuvant radiotherapy, last comment from Peter, and we had a great talk in one of the previous webinars, by the way, Sana, from Mitch Dowsett about the pathways of positive cancer. That was a fantastic talk by Dowsett. Before we go to Navita for the neoadjuvant radiotherapy, because I think that's a great thing that we need to explore more and more as surgeons, and use it more and more as surgeons, especially in certain subcohort of patients. Peter, you have your hand up.
Yeah, just 2 quick comments. Firstly, if we're talking about Ki-67, please, it's a very variably measured marker, and it's measured more reliably in some places. Now, we know it's very, very poorly done in terms of reproduction in multiple centers. So, for example, the latest trial, POET-AK, uses what we call Cognition Master, which is automated image analysis, because Mitch Dowsett has done a lot of work on this. So please make sure that your local Ki-67 measures are reproducible. That's my first plea if we're using that as a biomarker, especially change or absolute numbers. So please be very wary of that. Secondly, I personally wouldn't use extended tamoxifen in the younger woman, and this is probably what was said, because we know that the Ki-67 can vary by 40% just with the menstrual cycle, even with tamoxifen, because the estradiol levels will vary up to 100-fold in the normal cycle. And remember, tamoxifen is just a competitive agonist. So I think we have to be very careful for using tamoxifen in an extended way without ovarian function suppression in those women. So that's my only comments.
That's great. And with the key 67, we can speak for hours and hours and hours. So we'll stop talking about the key 67.
Yes, and one quick thing, I completely agree. The best way to do it, I'll actually agree with Ash. I do the same way Ash does. The same pathologist who read your first specimen should read the specimen post-surgery. This way you control for that deviation at least. And it's only a 2-week window period. So that actually will cut it short. At that, I will leave it.
Great. Rachel, happy 70th birthday for your father-in-law. Many thanks for joining us during your holiday. It's great to have you. Anyway,
Thank you.
Thank you for being with us. So we'll go for the neoadjuvant radiotherapy. Before that, I have your hand is up, Ravi, because we'll finish in about 10 minutes. Tell me, Ravi.
I just want to add one bit kind of agreeing wholeheartedly with Peter's comments with our own practice here in Aberdeen. I don't think we have used tamoxifen apart from being a temporizing measure ever in the 15 years I have been here, and even in the years before in England and Nottingham for neoadjuvant in the peri and the premenopausal. The postmenopausal, I must admit, brings quite a lot of questions, uncertainties, and confusion with neoadjuvant endocrine therapy, and isn't quite the same straightforward answer as with neoadjuvant chemotherapy. I think this is also complicated by the fact of how the Monarch E in the early breast cancer group showed benefit across tumor groups irrespective of Ki-67 status. Yes, I mean, I thought I would promise myself not to speak about Ki-67, but Oncotype DX is emerging, but again, chemotherapy cannot be excluded. Sandwiching many of these treatment modalities becomes a challenge. And I don't know, I'm afraid in our center, it's not just the acceptance, what shall I say, the widespread use of neoadjuvant endocrine therapy will always be second to other established treatments, I think.
That's great. I think there's about 70 questions in the question and answer section. There's no way that we can go through all of them. We're trying to go through as many as possible. Now, I think neoadjuvant radiotherapy is an entity that us, our surgeons, we don't think of. I think we've used it only once. We might be using it only for a second time in the past few years, mainly for those large locally advanced diseases that respond to chemotherapy, and you just think that they might need that little push to be able to operate on them and decrease the chance of recurrence. Now, but there's lots of other uses, and it's exciting to know about how it can potentiate immunotherapy and make it work even much better. So any comments about that, Navita? It was a great talk.
Sorry, yes, limitation of time, so I kind of whizzed through a little bit there. But I think, there is a great, I put down a couple of potential indications where, this might come in its way. And it's just, I think about just understanding that it's not, sequencing, it is about giving those, options, those treatments, whether it's chemo, endocrine, surgery, and radiotherapy. It's to optimize and to tailor it. So, rather than applying a kind of a broad brush to everyone. So, especially those patients that, are not responding to neoadjuvant chemotherapy as you would like, right? There's still residual disease there. And to my mind, harnessing this radiotherapy interaction with the tumor microenvironment, with an immune, agent, for example, is one of the strategies that we should be thinking along in these high-risk patients in terms of potentiating that. So, when you're giving radiotherapy adjuvantly in the breast scenario, you don't have that much of, immunogenic cell death or activation of immune response potential, because there are hardly any, it's microscopic residual disease that you're targeting. Whereas if you bring it in the pre-op setting, you definitely can harness that interaction in a much more, synergistic and tailored way for the patient. So that's, I think, an emerging field that is being investigated. Of course, all of it is in trials, not in standard practice. But yeah, that's one really potential group of patients that could benefit from this.
That's great. And before we go to Ravi, I think we need surgeons to comment about neoadjuvant radiotherapy. Andreas, Prof. Awad, and Marius. Andreas, do you want to mention anything?
Yeah, well, I think that neoadjuvant radiotherapy will be part of the armamentarium in the future. The things that we would need to consider in this setting, especially for lower risk tumors and so on, are matters that need to do with options and quality of life following, in the sense that many patients are very happy to have the opportunity of undergoing partial breast radiation or no radiation at all if operated for a small node negative tumor, which is the caveat of other things like, we are discussing surgical trials that are looking into the omission of sentinel lymph node biopsy as long as the patient is irradiated. And I think that they will fall shortly, because if you ask most women if they prefer a sentinel node biopsy to confirm that they are node negative or radiation therapy just in case, I don't think that they will opt for radiation therapy to avoid sentinel node biopsy, for example. So in a respective manner, this is a thing that we will need to take into consideration. However, Navita's comments on the interaction of systemic therapy, tumor microenvironment, and radiosensitization are crucial, because what we, you do not know what you do not know, and this is what you need to learn. This is what you need to understand. And I think that these trials will be pivotal in our understanding, first of all, the role of each therapy for the disease, rather than operating first, and treating afterwards, and then praying for the best. It's a little bit like that. On the other hand, then what we learn from the Prada study, and what we learned from a French study that was published at the EJSO some weeks before the Prada study, actually, is that reversing what we feel is standard sequence is not any taboo anymore. You just need to understand how things work. In the context of performing surgery after that, that will be a challenge for us surgeons, but we have learned a lot of things. There is not a difficulty to learn one more thing if needed. I mean, we do that not for our sake, we do it for the patient. So if the data that is there suggests that there is a benefit, then we'll just bite it and go further on with that.
Let's go to Prof. Ahmad Tariq Awad before we go to Ravi and then close the session. Prof. Awad?
Well, yes, it's a very interesting presentation of the preoperative radiotherapy. Actually, this is the natural sequence with the modern techniques of radiotherapy that we are having nowadays. I think we are going to go in such a situation. However, yeah, I think we are a little bit, I'm not perplexed, but actually we're going to change our thinking, because as we all teach in breast conservative or orthodox teaching, is that breast conservative, it's not a breast conservative surgery, it's a breast conservative therapy. We rely on radiotherapy for any residual microscopic tumors that are not detected. We depend on radiotherapy. Maybe as Navita told us, it's a very good solution, as we discussed before with some colleague of radiation oncology, that if you're going to do an oncoplastic complex one, like the reduction therapeutic myoplasties, the tumor bed is diverse all over the bed, and it's very difficult to how we are going to boost the breast, and actually are going to do a whole breast radiotherapy as a boost. So I think we need to learn more and more. I think they are coming with their techniques.
Ravi and then Marius, and then we'll close.
Ahmed, words stolen out of my mouth, spoken like an oncologist. So can I say thank you for all the speakers. Wonderful. I enjoyed myself, particularly Navita. I enjoyed your talk. I still remember the emails Yazan and I exchanged in the corridor conversations when the neoadjuvant radiotherapy was explored. We had a further discussion with Charlotte Coles and what have you. So thank you. Thoroughly enjoyed your talk. Couple of things I would like to say. I mean, the evidence base will be a little time coming. Yeah. And things would have moved on as well. I mean, there are centers that are never going to get MR-Linacs. I can tell you, even moving continents, we will not get an MR-Linac. But what we have is the new ethos machine now with risk of adapted radiotherapy, and you can churn out cone beam CTs and treatment within 5-6 minutes, very fast. So even small changes in position or immobilization, you see how much of a difference there is in dose distribution that you can correct for. So this is where Ahmed's words actually come into very specific relevance. We can now correct for those things which in the past were not possible, number one. Number two, Yazan alluded to one neoadjuvant radiotherapy who was not fit for chemotherapy, who was oozing blood, so needed radiotherapy first. And then we all have examples of this who went on to get a sprinkling or some sort of chemotherapy. In this case, it was an 80-year-old who got Taxol, Herceptin, complete response surgery afterwards. So we all have other locally advanced cancers, but what puts the fear of systemic therapy, neoadjuvant systemic therapy, is some of the rarer tumors, like say the sarcomatoid metaplastic cancers. These are rare, but will not respond to any systemic therapy you throw at them. The tumor just laughs at you. So radiotherapy is the key there. And now, you know that you can deliver higher doses of radiotherapy, so-called ablative doses, very safely. So that may be one key area where you could push treatment for a difference before evidence comes through. Breast is very political. You can't do anything outside the tram lines. We all accept that. I think more and more, I mean, better MDT working also, but more and more, I think there has to be the acceptance that radiotherapy can also do more. And I think education and webinars like this will go some way. Immunotherapy and immunosensitization with radiotherapy comes as a common topic. I remember going to Estro 4 or 5 years ago, and there was one whole corridor with melanoma patients who showed a response with radiotherapy before and then immunotherapy afterwards. I mean, now with the Keynote 522 study, I think there will be more acceptance of at least the node positive, bigger triple negative cancers. So I think there is a lot of work, an exciting field of work to start off.
That's great. And I think any closing comments from anybody? Marius, final comment before we close.
Thank you. Yeah, just a closing remark. We have gone a long way the last 50 years. We have shifted away from the traditional dogma of surgery treats cancer. And this webinar on neoadjuvant treatments, I think, is just highlights how important this is to change the paradigm and potentially improve outcomes for patients. Just a quick comment about Navita's excellent talk. We know that breast cancers are not very immunogenic, are mostly cold cancers. So if we can make them hotter cancers with radiotherapy, then potentially immunotherapy will have a greater role in these cancers, which at the moment is only for triple negative. So fascinating research in this field. Look at this space for neoadjuvant radiotherapy, and we do know that it is okay to do surgery after neoadjuvant radiotherapy. So that's my final comment. Thank you very much.
That's great.
Thank you for having us, Yazan.
Oh, thank you. Thank you, everybody. Sana, little comment, yeah.
A quick comment. Thank you very much, Yazan. The fact that I am a medical oncologist hosted by surgeons discussing neoadjuvant therapy in 2022, that indicates how far we have gone along the treatment of breast cancer. And it's only through this collaboration we can improve the outcome for our patients. It's a huge effort, brilliant surgeons and colleagues. That's how we can improve outcome for patients with breast cancer. It's through the neoadjuvant approach. It's the only way to know if our treatment really works, rather than, wait and see. It's the crystal ball for us medical oncologists. Thank you, colleagues.
That's great. Andreas.
I just wanted, because I did not disclose my conflicts. I really want the neoadjuvant thing to work. because then surgeons can move on to more interesting things than operating. Okay. That's what
I wish
just
all
want to say.
my colleagues like you.
That's great. So it's great to see that there's still more than 400 people online. We're beyond the 2-hour session. Now, in 3 weeks' time, we'll have a breast tech session, and that's the baby of Bahadir Gurgulu, the great surgeon from Turkey. We have 25 panelists and surgeons. It's a 3-hour marathon of oncoplastic breast surgery. Surgeons mainly from the Middle East, from Turkey, from Europe, including Italy, the UK, Portugal, Austria, you name it. So that will be great session. Already we have more than 500 people registered for that. Usually we had to move closer to 2,000 for those sessions, and Ricardo will be back to translate in Spanish for that. So keep an eye on the newsletter and to register for that. It will be great to have you all. Now, I cannot thank you enough for giving up your time, all speakers and panelists, to be with us tonight. Everybody also that has joined from different parts of the world, it's great to see as many of you online. So for people in the States and in South America, have a lovely day and have a good morning. For people in Europe, have a good evening. And for people in the Middle East and the subcontinent, have a lovely good night. Thank you, everybody.
Bye.
Thank you very much for